acute kidney injury. خدتوا إشي بالنفرولوجي محاضرات؟
لا ما أظن الصراحة ما أخذناش.
أعطاك الدكتور أشرف اليوم شيء؟
كان المفروض الساعة 9 بس تأجلت.
Okay. طيب, today we'll talk about acute kidney injury. So when we talk about kidney injury, kidney disease بشكل عام, we classify them as acute and chronic. And this is based on the time over which kidney dysfunction lasts for. So if things last for a short period of time, we will call it acute or subacute kidney injury. And if it's lasting for a longer time, we call it chronic kidney injury or chronic kidney disease in general. When we talk about acute kidney injury, we're talking about period of time over hours to few days up to a week. After that, we start calling it subacute kidney injury until 3 months. Okay, so if the duration of the acute kidney injury is less than 3 months, usually we call it acute or subacute kidney injury. As I mentioned already, when it's over a short period of time, like less than a week or so, we call it acute kidney injury. After a week until 3 months, we call it subacute kidney injury. And after 3 months, we start talking about chronic kidney disease or chronic renal failure. So the name, we used to call everything in the past, any elevation in serum creatinine that happens over a short period of time, acute renal failure. But the term failure means a very advanced stage of acute kidney injury. So in the last 20 years, they start calling it acute kidney injury. And when it's severe form, we call it failure. So acute kidney injury can range from mild acute kidney disease to a very advanced acute kidney injury, where we call it acute renal failure. Okay. The same thing for chronic kidney disease. It can also range from mild chronic kidney disease or stage 1, what we call, and to stage 5 or very advanced kidney disease. So when we say failure, this means most of the times an advanced form of either acute or chronic kidney disease. واضحة الأمور لحد الآن؟ في حد عنده سؤال so far؟
دكتور بس ممكن تعيد الفترة متى نحكي أكيوت متى كرونيك متى سب أكيوت؟
حكينا هذا الكلام يعني acute usually over few hours to 7 days or so. After that, we start calling it subacute until 3 months. After 3 months, we start calling it chronic kidney disease, or if it's severe enough or very advanced form of kidney disease, we call it chronic renal failure after 3 months. And if it's severe in the acute phase, we can call it, or we might call it acute renal failure, okay? So when we talk about acute kidney injury, we're referring to a rapid decline in kidney function, which, as I mentioned, happens over hours to days, and most of the time is less than a week. So the definition implies change in the kidney function, not the kidney structure itself. Okay, it's the kidney function, which might be associated sometimes with change in the kidney or impairment in the or damage to the kidney tissue itself, but sometimes it might not. So when we talk about acute kidney injury, we are referring to change in the function, which can happen, as I mentioned, over hours to days. What we mean by kidney function, most of the times, the most appropriate or the most important thing that represents kidney function is the GFR, or the glomerular filtration rate, which is the most accurate way of reflecting the kidney function. Um, so the kidney function in practice is measured by either a reduction in the GFR or the glomerular filtration rate, or the rise in serum creatinine, which we use in practice commonly, or the reduction in the urine output. This is what we mean by the change in function, a change in the GFR, serum creatinine, or the urine output. So there are many definitions that defined acute kidney injury, but the most accepted or the most used definition is what we call the KDIGO definition, which defines acute kidney injury by, as you can see, an increase in the serum creatinine by more than 26.5 micromole per liter within 48 hours, or an increase in the serum creatinine by more than 1.5 times the baseline over 7 days, or the drop in the urine output of 0.5 ml per kg per hour or less that lasts for 6 hours or more. Okay, so anything that applies, only what we need is just one of these things or one of these criteria to label a patient or the patient as having acute kidney injury. So we can have either one of these or two of these or the three of them. So any of these criteria, when it's there, the patient by definition is having an acute kidney injury. So this is the most accepted, let's say, definition of acute kidney injury that's used. But there are, you might read other definitions, but most of them will agree on this definition. Okay. This is the same definition. Within the same definition, the patient has an acute kidney injury. It can be mild, moderate, or severe. So the more the rise in the serum creatinine, the more the severity of the more the severe the acute kidney injury is. The same thing, the more the drop and the longer the duration and the drop of the urine output, the more the severe the acute kidney injury is. You don't have to know these numbers necessarily, but you need to understand that if the serum creatinine is higher and higher, this means the patient is having a more severe form of acute kidney injury. Or if the patient's urine output is very low, or if the patient is anuric, this means many times that the patient is having, again, a more severe form of acute kidney injury. Okay. This is another definition. You don't have to bother about these. So these are other definitions, but you don't have to necessarily know them. And we talked about that again. By definition, when we talk about acute kidney injury, we're talking about the change in the kidney function, which is in practice measured by serum creatinine and the urine output. So the structural changes or the damage is not a criterion for defining an acute kidney injury, but as I mentioned already, it may or may not present. I mean, the change in the kidney tissue itself, or the presence of active sediments in the urine analysis, or change abnormalities in the imaging, they don't have to be there, but many times they are there, but by definition, they don't have to be. This is again possibly a repetition, as we talked about already, subacute kidney injury. We're talking about a duration of less than 3 months, but more than a week. But an acute kidney injury, we're talking about a week or less. But when it comes to practice, acute kidney injury and subacute kidney injury are approached exactly the same, and they have the same etiology. They have the same approach, and they have the same management basically. So just these are some terminologies that you might read or encounter: acute or subacute. again, they have the same approach exactly and the same management. Again, this is a repetition we talked about already. This slide showed that, again, some emphasis on the definition. When we talk about, and sometimes when we talk about acute kidney disease, which you can see here, that involves both acute kidney injury and subacute kidney injury. They call them acute kidney disease, which is by definition less than 3 months. And then it comes here, the chronic kidney disease, when the duration is more than 3 months. But sometimes there is an overlap here. So a patient might have a chronic kidney disease, for example, with a baseline creatinine of 200 micromole per liter. Then he or she have another problem that happens acutely, which puts him or her at a picture or in a picture of acute kidney injury. So in this case, we call it acute kidney injury on top of chronic kidney disease. Suppose that the patient, as I mentioned, has a creatinine of 200 micromole per liter, then he or she develops, for example, severe diarrhea. So their creatinine or his creatinine will jump to, let's say, 450, 450 micromole per liter. This is what we call acute kidney injury on top of chronic kidney disease. So the baseline is around 200, but now it's 450, for example. This is what we call acute on top of chronic kidney disease. واضحة؟
دكتور ممكن سؤال؟
تفضل.
بس مو الكرياتين ممكن يزيد عندي مثلا بالبلاد بدون ما يكون في عندي اليورين اوتبوت انه يقل مثلا في عندي muscle tissue.
Yes. You don't have to have oliguria or drop in the urine output every time the creatinine is rising. Okay, so how common is acute kidney injury? Is it a common thing that we encounter? Yes, the answer is yes. So it's estimated that up to 20% of patients who are hospitalized in hospital, they have some form of acute kidney injury. And when it comes to the ICU, it is a much more common problem. Okay, so it's estimated that up to 50% in one of the studies that who are admitted to the ICU, they have some form of acute kidney injury. So it's a very common problem that we face in our practice, especially in hospitalized patients. This is how we approach any patients with acute kidney injury or subacute kidney injury. This is a very old way of classifying acute kidney injury or subacute kidney injury, and it's still valid. We still use that, and I think it's a very appropriate way of approaching a patient with acute kidney injury. So any patient who comes to us with acute kidney injury, as we saw by our definition, can be classified under one of these categories: pre-renal, renal, and post-renal. شايفين السهم انتوا ها؟ البوينتر شايفين السهم لما يتحرك؟
واضح.
طيب, so this is pre-renal, post-renal, and renal. What we mean by pre-renal etiologies, as you can see, anything that can lead to hypoperfusional state to the kidneys, which can include, for example, any patient who comes to us with severe hypovolemias, for example, severe vomiting or diarrhea, okay? Any patient who might have significant heart failure or hepatic disease or liver disease, sorry, like hepatorenal syndrome. Any patients, for example, who have any form of renal artery occlusion or stenosis, which can happen acutely or chronically, as well as anything that can affect the renal vein itself by compression or thrombosis. So anything that can impair the perfusional or the perfusion or blood perfusion to the kidney may lead to what we call pre-renal acute kidney injury. And it's a common cause of acute kidney injury in general, okay? When it comes to post-renal, we're talking about, if you can imagine, this is pre-renal. Yeah, this is the renal artery and this is the renal vein. Anything that can affect those in terms of uh, um, blood flow will lead to pre-renal. Affect the parenchyma itself will lead to renal, and after that, which affects the renal pelvis down to the ureter, bladder, urethra, can lead to what we call post-renal. Which post-renal, what we mean is a blockage to the flow of the urine, basically, simply. Okay. So anything that can lead to that, either, for example, tumors, stones, commonly, papillary necrosis, or anything that can affect the bladder outlets flow, or the bladder itself, which might impair or prevent the urine from flowing outside, can lead to what we call post-renal. Okay. When it comes to the renal etiologies, as you can see here, it's more diverse and more complex. So anything that can affect the small blood vessels or the glomerulus itself or the tubular structure on the interstitial structure can lead to what we call renal acute kidney injury. Okay. In general, pre-renal and acute tubular necrosis, they form like a very good percentage of all causes of acute kidney injury. So up to 75% of acute kidney injury as an etiology can be either pre-renal or acute tubular necrosis. So acute tubular necrosis is a form of what we call renal acute kidney injury. When you see here acute tubular necrosis, which can be due to either severe ischemia, severe hypotension, for example, or severe fluid loss, or nephrotoxic by, so for example, nephrotoxic medications or nephrotoxic pigments, for example, in rhabdomyolysis, or sometimes with intravenous contrast material. All can lead to acute tubular necrosis. So this is a very common form of acute kidney injury that we encounter in hospitalized patients in general. The same thing, anything that can affect the small blood vessels that supply the kidney itself or the kidney parenchyma, whether this is vasculitis or small thromboembolic phenomenon, can lead again to acute kidney injury, or anything that can affect the glomerulus, whether this is an immune-mediated problem or anything or direct injury can lead to glomerular disease, like anti-GBM disease, for example, systemic lupus erythematosus, as you can see, post-strep or post-infectious glomerulonephritis, and other few examples you can see here. The same thing, anything that can affect the interstitium, or that the kidney parenchyma is divided to glomerulus and tubular interstitial compartment, which can sometimes be affected by certain toxins or medications or infections. And anything which can lead to tubular obstruction of the nephron itself might lead to what we call, again, renal acute kidney injury. For example, Cas nephropathy, or certain medications which can lead sometimes to intratubular Cas formation. So it's very diverse, as you can see here, and many things can be happening, affecting either the glomerulus or the small blood vessels or the tubulointerstitial compartment itself. So this is a very important way of classifying any patient to us who presents to us with acute kidney injury, and it might help, or it will help us in approaching and managing the patient in general. Yep. Of course, this slide shows that some people might be at higher risk of developing acute kidney injury compared to others. So, for any patient who has an underlying chronic kidney disease of any form are at higher risk of developing acute kidney injury in general. People with diabetes, older age groups, patients with chronic illnesses like liver disease or heart failure, for example. So these are some examples are at higher risk of developing acute kidney injury compared to the others. Okay, this is something you need to pay attention to when you encounter a patient with acute kidney injury. That a person who is, for example, 8 years old with history of diabetes and some cardiac problem, they are at higher risk compared to a patient who is still, for example, in his 20s and has no chronic problems. Everybody can have or develop acute kidney injury, but in general, we are talking about the population in general, okay? This is a very complex diagram showing some important processes that can be involved in the pathophysiology of any patient with acute kidney injury. So this is, when we talk about acute tubular necrosis or pre-renal or post-renal or renal, so it's not a very simple process. It's not only a drop in the blood flow to the kidneys. It's per se, it's not the only problem. So when that happens, there are many things that will be going on, leading to what we call a cascade of events that will lead or exacerbate the kidney injury itself. الاتصال راح ينقطع بعد 10 دقائق، راح نجدد على نفس اللينك، ماشي؟ فإذا انقطع الاتصال بعد 10 دقائق نعمل تجديد على نفس اللينك إذا سمحت. So as you can see here, there are many things might be going on that will lead to what we call acute kidney injury. So everything in the kidney, parenchymal or blood vessels or tubular structure will be involved eventually. And inflammation, as you can see, is a very important part of the pathogenesis or the pathophysiology of any patient who develops acute kidney injury. It's just this slide to show you that, or make you understand that the process or any cause of acute kidney injury will lead to this many times to this form of complex process that will lead to what we call acute kidney injury. So in addition to the hemodynamic changes, you will see that the tubular damage will have some role. The inflammation, as I mentioned, has an important role. And the blood vessels with endothelial dysfunction, they will also lead to this picture, what we call acute kidney injury. And you don't have to pay much attention to every details in this slide. This is just, again, to explain to you that things are not only, even if we have hypotension, for example, only, or severe diarrhea only, what happens in the kidney itself is more complex than just a drop in the blood flow per se. For example, this is another diagram that shows in a patient with severe hypotension, for example, which will lead to acute tubular necrosis. So we're talking here about acute tubular necrosis. As we mentioned earlier, this is an important and a common cause of acute kidney injury in general. A patient who has, for example, severe hypotension for any reason, like severe diarrhea or is taking blood pressure medication, or severe heart failure, for example, this will lead, when they have decrease in the blood flow to the kidneys, this will lead to what we call ischemia, mainly affecting the tubular cells, which are most susceptible to ischemia and hypoxemia. Okay, so this is the starting point. With time, this will lead to tubular damage and microvascular injury, as you can see, and will lead to necrosis and apoptosis for these cells and a severe inflammatory cascade, which will involve cytokines and other inflammatory components. Okay, and that will take some time. During that process, you will see the creatinine is rising, the urine output might be dropping, and then after the patient recovers his acute insult, for example, his diarrhea stops, for example, or his blood pressure improves, for example, the blood flow will return to normal, and these cells will start de-differentiating and migrating and proliferating again. This is what we call the maintenance phase. And with time, if recovery has to happen, this will happen later on. So this process can take from hours to days, up to weeks, or up to 3 months, as we mentioned. Okay, so the recovery phase here can take up to 3 months, and the duration depends on how severe and the insult is, and so how severe the blood pressure drop was, for example, how severe and for how long. So the severity and the duration of the insult itself. This is what we call acute tubular necrosis, and this is what might be happening in terms of pathophysiological or changes that might happen, especially to the tubular structure of the kidney. We're talking here about acute tubular necrosis. We are not talking about other etiologies of acute kidney injury. And acute tubular necrosis is a very common form of acute kidney injury in general. حد عنده أسئلة هون؟
دكتور إنه البيشنت الريكفري يكون عنده كامل.
Well, this depends, as I mentioned, on how severe the injury was and for how long. Some of them might recover, or many of them might recover, but some of them might not. So some of them, if they have severe injury and for a long period of time, they might not recover, and they will enter the stage of what we call chronic kidney disease. Okay. I'm not sure if we need to talk about this. أنا في سلايدات كثير مش شرط يعني إنه we have to discuss every slide in details. This is just a slide that shows you, even in the, we're talking here about tubuloglomerular feedback. So even in case of acute tubular necrosis, there will be also some vascular factor in ischemic ATN. Even if it is damage to the tubular cells here, this will lead also to involvement of other structures in the kidney. For example, in acute tubular necrosis, there will be proximal tubular dysfunction, which will lead eventually to decreased absorption of sodium chloride. And when it reaches here to the distal tubules, that will lead to release of certain factors and will lead to vasoconstriction of the afferent arteriole here. So although we started with ischemia and tubular damage, we also ended up in other form of acute kidney injury, which will be a vicious circle at the end. So that the afferent tubular constriction would also aggravate the ischemia again, and so forth. Okay, this is what we call tubuloglomerular feedback. When it comes to obstruction, as you can imagine here, we talked about anything that will impair the urine flow from the kidney down outside might lead to what we call post-renal acute kidney injury. Whether this is a tumor, a stone, as you can see, or anything congenital narrowing here, or prostate problem in males, for example, or bladder problems, neurogenic bladder, for example, will lead to acute kidney injury if it lasts for a long period of time. So in this case, any form of obstruction will lead to elevated pressures in the obstructed part and dilatation of the ureter and the pelvis here, right? Then if it lasts long period of time, that will cause damage to the nephron itself. What we mean by that, atrophy, interstitial fibrosis, and at the end will also lead to scarring of the glomerulus itself. So this is a slightly different way of or pathophysiology in obstructive causes in general. The command busy slide, you don't have to know the details. We talked about the inflammatory process that happens in a patient with acute kidney injury. Just for people who are interested in research in general, you will read many times that there are many genes that are upregulated and some genes are underregulated or downregulated in patients with ischemic acute kidney injury. Um, we'll talk about that later on, maybe if we have time. So why does the GFR drop in a patient with ischemic ATN or ischemic acute kidney injury? So there are many reasons why the GFR drops. As we talked, the decrease in renal blood flow is the starting point. This will lead, any drop in the renal blood flow will lead to drop in the GFR. We talked about. طيب كمل شو رايكم؟ سامعني؟
دكتور سامي.
طيب, this slide just mentions the reasons why the GFR drops. This is what we talked about earlier, which is the most important thing that reflects the kidney function. We're talking here again about ischemic acute kidney injury or acute tubular necrosis specifically. So anything that can lead to severe renal hypoperfusion will lead to that. So the drop in the renal blood flow itself will lead to drop in the GFR. This is one thing. We talked about the tubuloglomerular feedback, which lead to afferent arteriolar constriction. And we talked about the tubular obstruction. As we mentioned earlier here, so the tubular damage itself will lead to sloughing of these cells, and this will lead to obstruction of the tubular lumen itself, which also will play a role in the drop in the GFR, okay? And there's also what we call the back leak. So these cells, the tubular cells, when they are sloughed, we will be left with the glomerular basement, or sorry, the tubular basement membrane. So in the absence of these cells, when they are sloughed, the glomerular filtrate will back leak from the lumen to the extra lumen compartment. This also will lead to drop in the GFR. This is what we call back leak. So as you can see here, this is another mechanism or another cause why the GFR drops in these patients. So there are many things that might be going on which will lead to the drop in the GFR. It's not the only is not the drop in the renal blood flow only that will lead to that. So all these mechanisms will lead to drop in the GFR in patients with acute tubular necrosis. So under the microscope in a patient with acute tubular necrosis, and this is the normal glomerulus and the normal kidney tissue. This is the glomerulus, and this is the proximal tubule, and this is the distal tubule. This is how they look normally under the microscope. When we talk about acute tubular necrosis, so the main compartment that's affected is the proximal tubule, these ones. So this is normal, and this is acute tubular necrosis here. As you can see here, this is the glomerulus. But when you look at the tubules, you don't see the cells as healthy, the tubular cells as healthy as in normal tissue. Even you don't see them at all if you look here, pay much attention. So they are all sloughed and they are necrotic now, and they accumulate in the tubular lumen, leading to, as we talked about earlier, tubular obstruction, which will also more and more lead to drop in the GFR. So the main thing that's affected in a patient with acute tubular necrosis is the tubular compartment, not the glomerulus under the microscope or pathologically. Okay. This is another view, the same picture. This is normal here, and these are the tubular cells, which they look very damaged. The cells, if you compare it here to normal, you see the cells are very nice with the nucleus and they are lining the lumen, but they are not here, right? They are all sloughed. If you look at this very big lumen, is filled with this sloughed material and debris, which also lead to more drop in the GFR. Okay, now if you encounter any patient with acute or with a rise in the serum creatinine, we already talked about acute or two forms of kidney disease, acute and chronic, and they might both present with, as we talked about,
دكتور صوتك مقطع.
جابوني
دكتور الصوت كان
سامعين ولا نايمين ولا لا؟
الصوت كان بقطع دكتور.
ها؟
صوتك كان رايح.
كيف رايح؟ طب ليش ما تحكوا لي؟
ما احنا حكينا بس انه سلايد هذا بس.
مين؟
ما في صوت.
سامعني؟
هسه
طيب, how would you know that a patient with acute or with a high serum creatinine who comes to us for the first time? So if you see a patient for the first time that he has or she has a high serum creatinine, the question now, how would you know whether this is acute or chronic? This is the main question now. So the easiest thing to look at or do is look at previous serum creatinine levels. Okay, so if you see that this patient's creatinine today is 300 micromole per liter, which is high, and 2 weeks ago it was 80 micromole per liter. So what do you call this? حد يجاوبني. So you call this acute kidney injury because serum creatinine 1 week or 2 weeks ago was normal. Now it's high. You call this acute or chronic kidney disease? We call it acute kidney injury because the serum creatinine increased over a short period of time. But we don't have these serum creatinine readings available all the time. So we might depend on other parameters to define whether this, or to know whether this patient has an acute or chronic form of kidney disease. So sometimes we need to look at the hemoglobin level and some bone affection, what we call renal osteodystrophy, on imaging or on biochemical testing. The kidney size, as well as some serum electrolytes, will help us defining or knowing whether this patient has acute or chronic kidney disease. And despite that, sometimes we might not be able to know even. So we'll try our best. Sometimes we might not know. Okay? But the easiest way is to look at previous readings, زي ما حكينا, previous serum creatinine readings. Okay, so suppose that we have a patient now with acute kidney injury. What's the approach? As usual, we start with the history, and again, we look at our previous discussion Our previous slides, we talked about pre-renal, renal, and post-renal acute kidney injury. So these are some examples of what we talked about, pre-renal, renal, and post-renal. And we direct our history based on the differential diagnosis in mind. So if we're thinking that we are dealing with pre-renal, or if we are asking about pre-renal acute kidney injury, a few things we might ask about is, for example, the patient has any form of fluid loss, like diarrhea, vomiting, for example, severe bleeding. The patient has, for example, anything that can affect the arteriolar component of the glomerulus, like ACE inhibitors or NSAIDs, or if there are symptoms, for example, of hypotension or in general, like dizziness, or if the patient has some form of chronic kidney disease that will lead to renal hypoperfusion, for example, heart failure or liver disease, okay? So the same thing for renal and post-renal. And then we continue with physical examination. Again, we direct our physical exam depending on what we're thinking about our patient might be having. And again, if the patient, we're thinking about pre-renal, we need to check his blood pressure and pulse, check his JVP, okay? If we think that the patient has post-renal, we need to check his bladder, abdominal exam, pelvic exam sometimes. We might need to examine his prostate and check if he has a Foley's, for example. The Foley catheter might be sometimes blocked or kinked for any reason. Or if we're thinking that the patient has a renal etiology or a renal cause of his acute kidney injury, we need to see again, look his blood pressure, if there's any signs of vasculitis, for example, fever, purpura, libido reticularis, for example. Okay, this is how we do. So history, and then physical exam, and then investigations. These are some examples of the investigations we might ask for, and these are many of them, but we don't order all of these for everyone. This is just the investigation we might ask in a patient of all forms of acute kidney injuries, but we don't order them all for everyone. So if the patient is clearly having, for example, diarrhea, we don't have to ask for ANA, anti-DNA, and ANCA, and these things, okay? So we direct our investigations based on the differential diagnosis we are having when we see our patient with acute kidney injury. A very important test we need to do, or we always have to do, is the urine analysis. And there are many things we can benefit from doing a urine analysis for our patient with acute kidney injury. The urine has many things to look at, from color, from dipstick testing for proteins, for example. And we look at the urine under the microscopy. Sometimes we might need to do urine cultures, for example, or blood cultures. So there are many things that we need to look at when we do the urine analysis in a patient with acute kidney injury specifically. This is how the urine analysis might help us. So in a patient with pre-renal, many times you will see no active or many active changes in the urine. So you will see no proteinuria and no many cells, or sometimes you might see only very trace proteinuria, okay? But if you have a renal etiology, you might see more active sediments. What we mean by that, cells and casts sometimes, okay? These are some examples of urine casts you might see in a patient with acute kidney injury, and we see them mainly in a patient with a renal form of acute kidney injury. So these are red cell casts. We see them many times in, for example, glomerulonephritis. These are white cell casts. We might see them in a patient with acute interstitial nephritis. These are granular casts. We might see them in a patient with acute tubular necrosis or other etiologies, but they are not specific for acute tubular necrosis. You can see them in other forms of acute kidney injury, but if you think that the patient has acute tubular necrosis, this is what you see many times. These are hyaline casts. They are very transparent. These are not very significant in a patient with acute kidney injury. Even you might see them in normal urine. One thing we can do also, investigating a patient with acute kidney injury, is doing what we call urine sodium concentration and fractional excretion of sodium. So the urine sodium might be low in a patient with acute pre-renal acute kidney injury, but not always. Again, not always. As well as the fractional excretion of sodium might be low, less than 1% in a patient with pre-renal acute kidney injury. And again, that's not always. Okay, so these tests we can do, but if we need to know how to interpret them, okay? So not every patient with a low urine sodium necessarily has pre-renal. The same thing, you might see pre-renal acute kidney injury in a patient who have urine sodium of more than 20 or more than 30 sometimes. But this is just some guidelines we might use sometimes, and we know how to interpret these tests when we order them. So urine sodium and fractional excretion of sodium might be helpful sometimes. Again, we need to do an ultrasound sometimes to rule out, or many times to rule out obstruction. We talked about the post-renal etiologies of acute kidney injury. We talked about sometimes you might have hydronephrosis due to stones, for example, or bladder problem. So sometimes you might need to do some form of imaging to check that. Either an ultrasound, sometimes a CT scan, depends, okay? Kidney biopsy or renal biopsy is sometimes necessary to diagnose or to know the etiology or the exact etiology of acute kidney injury. But this is, as you know, is an invasive procedure. So we don't do kidney biopsy or renal biopsy unless we think that the patient has a renal cause or an intrinsic renal cause of acute kidney injury. This is one. And the result will change our management, okay? So if the results will not change our management, we might not do that, even if we think the patient has acute kidney injury due to a renal cause. For example, if a patient we think has acute tubular necrosis, which is a renal cause, we don't have necessarily to do kidney biopsy because the management is always supportive, right? But if we think that the patient, for example, is having acute glomerulonephritis due to systemic lupus erythematosus, for example, and in this case, the biopsy will help us first to diagnose accurately the problem, and second of all, will guide us in managing this patient because such patient might need, for example, corticosteroids or immunosuppression to treat, which is a more specific form of treatment rather than just supportive form. Okay, so kidney biopsy is not done for every patient with acute kidney injury. We do it if that will change the management of the patient in general, okay? Again, this slide will show you the spectrum of pre-renal acute kidney injury and ischemic ATN. So pre-renal acute kidney injury and ischemic ATN are a spectrum of disease, okay? So if the patient has, for example, mild hypotension due to any cause, they might have mild pre-renal, which is many times reversible when you correct the underlying problem. But with time, if the insult continues or if it's more severe, we will reach to what we call mild ATN here, for example, where the reversibility will be less expected in a short period of time. And if the injury continues for a longer period of time and more severe, we will reach what we call severe ischemic ATN. We're talking here about ischemic acute tubular necrosis. So if the injury continues for a long time, or if it was so severe, like if a patient, for example, has severe hypotension for a long time, they might develop severe ischemic ATN, and it is less likely to be reversible, or if it's going to be reversible, it will take a longer period of time. So this is just something you need to understand, that pre-renal and ischemic acute tubular necrosis is one thing, but depends on the severity of the injury itself. If the injury is mild, things will be reversible sooner than later. If the injury is severe, the injury will be less reversible and it will take longer period of time. And sometimes, as we talked already, it might not be reversible at all. So it's very important that we need to interfere and evaluate our patient early on if he presents to us early on. But sometimes they present already in the late stage, so you might not be able to do much for them. Okay?
دكتور سؤال إذا سمحت.
تفضل.
دكتور هسه لما أنت حكيت إنه نفس السبيكترم فإنه ممكن تبدأ مال بري رينال بعدين تتطور لسيفير اسكيميك
Right.
ATN. هسه دكتور في بكون كرونيسيتي في الموضوع إنها بتاخذ وقت لحد ما تصير سيفير اسكيميك ATN.
Yes, again, it depends. If the injury lasts for a longer time, it will lead to severe form of ATN. Or if the injury was very severe from the beginning, it will take a shorter period of time to cause severe ATN. So it depends on the severity of the injury and the duration زي ما حكينا الشيء.
وإذا الديوريشن طول بصير الاسكيميك ATN ما بنعتبره AKI بصير CKD.
إذا طول أكثر من 3 months طبعا نحكي the duration is 3 months or more when we
أكيد ببطل سب أكيوت.
بالضبط.
أوكي تمام شكرا.
اوكي يعني اذا الانجري عنده الكرياتين ضل عالي لفتره طويله اكثر من 3 months, we're talking here about we start talking about chronic kidney disease, and the same patient we're talking about. If things recover before 3 months, we're talking about acute. If it continues for 3 months or more, we'll start talking about chronic kidney disease.
وهذا بيفرق للمانجمنت والابروتش تاعنا انه يكون كرونيك او اكيوت صح؟ احنا بعرف انه نحكي هنا اكيوت.
Right.
فمهم انه نحدد بين انه اكيوت او كرونيك عشان المانجمنت بتختلف.
Right.
تمام. يسلم شكرا.
This is just a busy slide again showing you the possible complications that might happen in a patient with acute kidney injury. Although we are talking about acute kidney injury, but this can affect every organ in the body, right? So as you can imagine, the kidney is very important in regulating the acid base, the fluid balance, the electrolytes in our body, okay? So from complications can range, for example, from volume issues. So people, if they develop anuria or oliguria, they become hypervolemic, right? So they will have edema, severe hypertension, sometimes pulmonary edema, right? Electrolyte disturbances from hyperkalemia to hypohypernatremia, all of these things, hypocalcemia, and metabolic acidosis, as you can imagine. They might develop anemia due to many different reasons, and they are at higher risk of bleeding due to different reasons as well. Okay, due to all these complications, the patient might be at risk of developing cardiac problems and arrhythmias, as well as GI bleeding. So they are at higher risk of developing GI bleeding, the same thing, as well as infections, especially in patients in the ICU. So these complications are more in the patients who are admitted to the ICU, but can happen in any patient with acute kidney injury. depending on the severity, the duration, as I mentioned, and the interventions that happen to the patients. Okay, so infections, as you can see, may be responsible for many causes of the deaths that happen due to acute kidney injury. Okay, so a patient might not necessarily die from the acute kidney injury itself, but might be many times they might die from infection as a complication of being in hospital and in the ICU. So this is not something very simple, especially when the patient is in the ICU. So many things can happen. And as we will talk later about, it's associated with significant morbidity and mortality. The treatment or the active treatment depends on the cause, right? Whether, again, we're talking about pre-renal, renal, and post-renal. Sometimes the patient might be just in need for some fluid replacement if they have just mild pre-renal or mild ATN. But sometimes treatment might be more aggressive. And as we talked about, if the patient has severe form of acute glomerulonephritis, they might need corticosteroids, immunosuppression, or plasmapheresis, for example. If the cause is post-renal, many times we need to relieve the obstruction, okay, by either putting a Foley catheter or nephrostomy or surgery, depends, right? So the management, again, depends on what's going on or what's causing the acute kidney injury, and can vary from simple management to more aggressive and heavy management, what we call. In addition to the specific management we talked about, there are supportive managements for everyone who has acute kidney injury, taking care of their fluids, balance, electrolytes, acid-base, nutrition, okay, to prevent the complications we talked about from bleeding, cardiac problems, arrhythmias, anemia, okay? And some people might be in need for urgent dialysis or acute dialysis. Okay, so if the patient is having refractory pulmonary edema, not responding to medications, for example, or if he has severe hyperkalemia, not responding to conservative management, or severe acidosis, again, not responding to medications, or acute uremic syndrome in the form of pericarditis encephalopathy, for example, or severe uremic symptoms of nausea, vomiting, itching, these things. These are indications for dialysis in the acute setting of acute kidney injury. Okay, sometimes we might need to do that in a patient to prevent the complication that the patient might be suffering or facing in the acute phase, okay? And the dialysis can be different forms, hemodialysis or peritoneal dialysis. So this is what happens to patients who develop acute kidney injury. We're talking here, this slide is talking mainly about ICU patients who develop acute kidney injury. So around 13% will require long-term dialysis over 1 to 10 years follow-up. So not all of them will recover, as we talked about. Some of them will end up needing long-term hemodialysis, a small percentage. And around 40% will end up with some form of chronic kidney disease, from mild to moderate to severe, depends. They are at higher risk of developing cardiovascular and cerebrovascular events in the future. And around 30-35% might die by 6 months and 50% by 5 years. Not necessarily from the acute kidney injury itself, but from other comorbidities or complications of the hospital admissions. And here again, we're talking about ICU patients mainly, okay? These numbers may apply more to ICU patients. Okay, and the death is usually due to a sequelae or a consequence to or a complication of acute kidney injury. we talked about infections and cardiovascular problems that might happen. Okay, so the acute kidney injury itself per se may not be necessarily the cause of death, but the complications the patient might suffer or have. هل عنده أسئلة؟
دكتور ممكن سؤال؟
انتوا العدد 200 حاضر 50 بس، في سبب يعني معين ولا كيف؟ الوقت مش مناسب ولا الجو مش مناسب ولا مش interested ولا ما بعرف شو السبب؟ حدا بيعطيني أي فيدباك أو بعلق على الموضوع؟ مين السي ار؟ حاضر السي ار؟ مين السي ار؟ مين السي ار حاضر؟ شو اسم السي ار؟ ولا حدا بيعرف اسم السي ار منكم؟ كيف تتواصلوا مع بعض الآن؟
دكتور في لكل جروب سي ار وفي سي
لا
ار
السي ار
الميجر.
السي ار الميجر.
سي ار الميجر اللي هو باسل عواقله.
مين؟
باسل عواقله.
باسل موجود؟ مش موجود شكله. طيب مين عنده سؤال؟
دكتور ممكن أسأل؟
تفضلي.
بالأكيوت كدني إنجري هو عادة بيكون
مين انت
بايلاترال
عفوا؟
ولا
اول شيء
يونيلاترال؟
شو اسمك؟
سماح العمري. سماح العمري.
ايوه.
بيكون عادة بايلاترال ولا يونيلاترال in one kidney يعني؟
When we talk about kidney injury, we're talking about kidney function, and the kidney function is reflected by serum creatinine and urine output, and the serum creatinine and the urine output is or reflects the function of both kidneys if the patient has two kidneys, or one kidney if the patient has one kidney. واضح الجواب؟ يعني of course the two kidneys.
شكرا. Thank you.
GFR هون شو وضعه؟ شو اعتباره هون؟ إذا إحنا كان الأوتبوت الكرايتيريا تاعتنا هي الأوتبوت والكرياتينين في السيرم.
Yes.
GFR عشان بس نقيس الأداء خلال العلاج أو التطور يعني ولا شو؟
Yeah, when we talk about kidney function, what we mean by kidney function is GFR. Okay, but we don't measure the GFR all the time to everyone. Okay, so the most commonly used parameters in practice are the serum creatinine and the urine output, and they are not, and there are some criticism about using these as in the definition of acute kidney injury, but because sometimes they might not be very much accurate. Okay. So the most accurate way is measuring or estimating the GFR, but in practice we do it if you want to, but the most commonly used or the most simple and quick way of knowing the patient has acute kidney injury is looking at his serum creatinine and sometimes the urine output. And the GFR, if you want to calculate the GFR, many times it also depends on the serum creatinine. So GFR is calculated using some equations, and many times the creatinine is part of the equation, is part of the equation that we use to estimate the GFR. ما بعرف جاوبتك ولا لا؟
تمام وصلت. يسلم دكتور.
حد عنده أسئلة أخرى؟
لا ما في.
طيب إذا ما حدش عنده أسئلة معناته بس الكل عنده علم كان إنه المفروض إنه في محاضرة اليوم صح؟
دكتور.
في واحد كاتب لي not all groups are supposed to attend only certain groups. ليش؟
لا دكتور، المفروض هاي المحاضرة للميجر كامل.
هيك بعرف أنا كمان. قاعد مين هذا اللي كاتب لي not all groups are supposed to attend only certain groups؟
هو كان مفكر إنه هذا راوند،
إنه إيش؟
إنه هو راوند، يعني راوند لجروبات معينة.
كيف راوند؟ لكتشر هاي.
هو يعني بالغلط يعني.
هو مفكر إنها راوند مش لكتشر، فبس بالراوندات إحنا بس certain جروبس بنحضر، بس هي كتب ماي ميستيك إنه غلطان.
ما أنا بديش أعلق أكثر من هيك. طيب هذا ظل. طيب إذا ما حدش عنده أسئلة شكرا لكم.
شكرا دكتور.